Good evening, everybody, and welcome to the IHOPE monthly calendar of events. The webinar today that we have is on eye care and the carbon footprint. We'll be having Dr. Merle Fernandez, who will be in conversation with Mr. Thulsiraj Ravilla. To introduce both of them, I would like to request Dr. Rajanarayanan, who's the IHOPE investigator, principal investigator, and I'll hand it over to him. Dr. Raja?
Yeah, thanks, Sarnaz. I welcome you all to the monthly IHOPE webinar on eye care and carbon footprint. We have two stalwarts today. Our chief guest is Mr. Thulsiraj Ravilla, who is the Director of Operations at Aravind Eyecare System and the Executive Director of LICO. And he has been an advisor to the various government bodies, including NPCB, WHO, and he has also been the regional chair, Southeast Asia regional chair of IAPB. And he has a very keen interest on green initiatives. And another person who is probably the apt moderator for this session today is Dr. Merle Fernandez, who is the director of the Center of Excellence at V Prasad Eye Institute, the Kallam Anji Reddy Campus at Hyderabad. She will moderate the session, and since both of them have been working on similar lines on reducing carbon footprint, sustainable planet, that has to be ingrained in our DNAs. It's not easy. It's one thing to talk, but it's another thing to do. And both of them have been leading major initiatives at their respective institutes. And I now hand over to Dr. Merle Fernandez. Over to you, Merle.
Yeah, thanks, Raja. It's really good to be able to kind of conduct a session on eye care and the carbon footprint, because increasingly we realize that this is where we are headed, because we know that almost 4 to 5% of carbon dioxide emissions are from the healthcare sector alone. And ophthalmology is one of the major contributors towards that because of the number of or the volumes of cataract surgeries that we do. So to set the perspective, I'm going to ask Mr. Thulsiraj, what are his thoughts on the role of healthcare in general and eye care specifically on the carbon footprint?
I think in the recent years, I think we are becoming more and more aware and conscious of the climate change, thanks to the advocacy of people from India and other places. As with everything, we've started getting some evidence as well, about to the extent to which the carbon gas emissions are there, and some Hello. Of the evidence.
Hello.
Can you mute?
Hello.
Can you mute? So please mute.
Request everyone to mute, please. Yeah, thanks.
We also started getting evidence in the recent years, and what the evidence is showing, as Merle said, that overall globally, healthcare accounts for about 4% of the carbon footprint. So that may seem sort of small, but then if you look at the contribution of more developed countries, where the healthcare is a lot more universal, where the population is older, at the top of the line is US, which accounts for about 10 to 12% of the green gas emission in the country. So a major contributor as a single industry or an entity. And then given India's population, India's today's inadequate coverage of healthcare and the rapid aging of population, we will also move in that direction if it is business as usual. So that is one caution that we need to have. And within healthcare, I think eye care is, I don't think we have teased out how much is the contribution by eye care in granularity, but it's likely to be a significant contributor. In my rough estimate, India is performing 10 million surgeries or more per year, including cataracts. That probably may be the highest volume of surgery that's being done. And you can recognize with the amount of effort that goes for each surgery, the patient making at least half a dozen visits, pre and post-op, all the consumables, all the equipment that is used. So I don't have the numbers, but I would probably say iCare contributes for somewhere to 10 to 15% of the total healthcare carbon emissions. So we are a significant contributor, and I think to that extent we have significant responsibility to become aware and do what we can to reduce that.
Thanks. Yeah, so I think that's very pertinent, because the volumes of surgeries that we do, in the country as a whole, that's really huge, and we haven't actually, gone through the efforts of trying to calculate. It's not an easy task. I think it's pretty difficult to just calculate what are the greenhouse gas emissions for a single cataract surgery. And I'm sure that when you published your paper a couple of years ago, I'm sure that that challenge would have arisen in how exactly do you calculate it. But let's step back a little, because I know that Aravind has been doing a lot, and I just want to know, generally, what do you think eye care organizations have been doing in terms of reducing carbon emissions? Have they reached the point where they're actually thinking about it, or is it still not on our radar?
I think if you take for the majority, I would say it is still not in the radar. But then I also been surprised to look at how many people are actively working in this space. But I think today they are exceptions rather than the rule. But I think even within organizations where this consciousness is there, it is amongst the few. But fortunately, that few are able to influence how that their organization works on this aspect of it. So if your question is, are we there in terms of awareness and having things in place, my answer really is a big no. We still have a long way to go.
Yeah, so I think it's just kind of what we're doing right now is like little drops in the ocean, and there's a lot more that we can actually do. And I'm sure that today's discussion on what has been happening in Aravind generally, and that would actually give a lot of people ideas on what they need to do going forward. So let's go to the big question now. So what exactly has Aravind been doing? And I'll start with asking you a question on, so when we look at what are the contributors towards greenhouse gases from an eye care perspective, what are all the different components that you have to take into consideration? It's not just one small bit. There are multiple things that come into this picture when we're trying to figure out, okay, how do we go about bringing down the greenhouse gases that we emit?
So first is to recognize, as providers, we have some self-imposed or not self-imposed, externally imposed boundaries on how much we can do, especially if you are not very large. So a lot of what we have been doing has been within that boundaries. Maybe I can just share a simple model. I think I'm allowed to share, I think. Is the slide visible, Merle?
Yes.
Yeah, okay. So the way we have gone about approaching this problem is to recognize that for providing eye care, you require resources, to start with. Everyone knows that, and that would be infrastructure, the energy that you need, and then you have to put in some of the processes in place, the supplies and consumables that we use. So the infrastructure itself, there is scope for bringing this consciousness. Now, for instance, when you look at infrastructure, how the building is designed. Now, how much are we leveraging the natural lighting, the natural ventilation? And that becomes, to that extent, your energy needs reduces. And again, when it comes to energy itself, how are you sourcing them from? Is it all grid energy? Grid energy today is largely coal-based. There's also some hydel and things like that. But now we have options of solar, wind, and you can also have your own generation. But even in this, I think the very first step would be to see what can you do to reduce the energy requirements. And we were quite amazed, that by replacing, for example, simple things like lighting to LEDs, going in for more efficient fans. And the big consumers are what they call as the high vac, the air conditioning systems. The chillers tend to be very inefficient. So replacing the chiller motors and even water motors. Just by doing that, we were able to save close to about 20% of our energy consumption. So much so that all investment on that front was recovered in less than 2 years' time. That's a phenomenally high rate of return by any business standards. So we have this opportunity for reducing power consumption and then also sourcing power consumption from green energy sources. So today, all the large hospitals are close to 80-90% on green energy. Then, of course, one can look at what we buy, are they single-use, multi-use? And recycling, again, offers a lot of opportunity. And then again, we are bringing this largely under resource or infrastructure because you have to plan for it. Like in pretty much all our hospitals, excepting in Madurai, all the water that we use, which will be, I think today, to the tune of about 2 million liters, 20 lakh liters a day, is completely recycled and reused within the system. And to do that, you need to invest in that infrastructure. And we have gone for an organic plant called as DWATS. And so these are all the stuff that one can do in the infrastructure itself. So I'll sort of stop sharing now. So this is how we have gone about thinking about climate change, by putting them into two buckets. One is what can we do to reduce the carbon footprint on the infra side, and then the other side, which I can talk down the line, is about how do we do things in a certain way that we are reducing the carbon emission on the day-to-day operations.
Yeah. So just one question before we go ahead. So whenever you set up a new unit, do you actually follow the IGBC code, the Indian Green Building Code, in order to ensure that the infrastructure setup is following those guidelines?
To the extent we can, I won't say 100%, but then to a large extent, we try to adopt that. I think that code is very, very strict. We have not gone all the way to very strictly adopt that code. In the sense, if they came and did an audit for Green Building Code, we may not qualify. But we know that we are a lot more energy efficient than most other buildings would be. Yeah.
Right. And one more question pertaining to the purchase of green energy. So what is the option that you have in Tamil Nadu for buying green energy? Is that hydel, or is it wind, or is it solar from elsewhere? How do you go about it?
So this is sort of here is where I think we as a sector may have to lobby with the government, because I think today there is a growing number of people who are investing in solar farms and wind farms. And now they have, like, these rules vary from state to state. In Tamil Nadu, the rule is that the high tension consumers or the industrial consumers are the only ones who can get into those kind of agreements. And today we have gone into agreements with both solar and wind farm. So depending upon the availability of the vendors and that capacity that is there. Like for example, Tirunelveli, we have a hybrid combination of solar and wind. So Tirunelveli is 100% on green energy. But in Madurai, we are only with solar energy. So there we are at around 70-80% green energy. And in all the hospitals, to the extent possible, we have captive rooftop solar farms as well. So together we have about 1.5 megawatts across all the hospitals. So pretty much every hospital has become a standard. You build, you put solar panels on the top. Yeah.
Yeah. All right. Okay. So I'll move on to asking you the next part of the Aravind, the AECS contribution. So when you looked at, say, cataract surgery alone, what did you find in your paper that you had published on how much cataract surgery is contributing towards these greenhouse gas emissions? What are the measures that were taken at Aravind to try and bring that down? And if you compare with the West or the developed world, what are the differences that you found?
Okay, two things. I think people who know Aravind, we do certain things which many others may be doing, but then we are quite open about our practices, which is certainly not the West does. No, so what we have realized is that the carbon footprint is directly proportionate to how much you consume. No, so the more efficient you become, I think efficiency again is consumption by output. So if your per unit consumption becomes less, to that extent your carbon footprint also becomes less. So this applies to everything. Like for instance, now we have certain protocols for changing gowns, changing gloves. Now we use we still have two patients being operated in the same operating room, with two beds, not two patients, two beds for each surgeon, so that we are making that whole process more efficient. In the sense, we use the operating room less, so by completely eliminating changeover time. So we have been adopting these kind of work processes, and then we have been very tightly monitoring the outcomes of it. Now, like a recent publication came out of an opportunity that COVID brought to us. With the advent of COVID, there was concern about more people in the operating room. So we pretty much followed the Western protocol and a lot of cleaning up between surgeries and so on. And then we compared the infection rates during that period, which was some 60,000 odd surgeries during that period, with the pre-COVID, where the protocol was as usual. And there was literally no difference in the infection rates. So basically saying that we are putting a lot of effort into processes or precautions which don't have an impact on reducing infections, which is the main reason why we use so much of reuse of, single-time use and things like that. So that's one part of it on the surgery. So the quantum of waste that happens from each surgery is kept to the minimal. Wherever it is safe to use multi-use, we would use multi-use with sterile precautions and things like that. So the consumption per surgery, we have brought it to the minimum based on our protocol. That it could be better, we don't know. The other thing that we do is in the whole work process, how we the whole clinical protocol, we become more or less like a one-stop shop, and then also try to do everything on a single visit. One, we don't have appointments, which means people don't have to make a hospital-specific visit. They can add it on to something else. So thereby we're reducing travel by the patient to some extent, to that extent reduction in carbon footprint. And then once they come in, all cross consultations and everything would happen on the same visit itself. And in case it's a surgical patient and the patient is willing for surgery, now we would be happy to operate on the patient the following day, subject to all medical parameters being all right. So we pay a lot of attention to minimizing the number of visits they have to make to close an episode of surgery or otherwise. Lasers and everything we try to do on one visit. So the whole attention has been on that. Even in eye camps, when we prescribe glasses, we give glasses on the spot so they don't run around trying to buy the glasses. So wherein other than cost, they're also spreading the carbon footprint by travel and things like that. So a lot of attention has gone into designing that whole delivery process to minimize the effort. So we have taken that outlook of looking at a little bit more holistically. It's not just our effort, but also the patient's effort. I think that combination or that approach seems to have helped in reducing the carbon footprint to a great extent. Yeah.
Yeah, so I think actually COVID has taught us a lot, because we were trying to minimize the visits of patients to hospitals, and in one way they were not able to visit us because of the lockdown and restricted transport and things like that. So I think teleophthalmology has played a great role there. So does that also play a similar role for you? Because in LBP, it's continuing even now that though it's not, a lot of patients still prefer to come to the institute. We try to dissuade them. And as far as our cataract surgery follow-ups are concerned, we have minimized visits for the patient. We try to ensure that they go to vision centers or secondary centers to get their glasses. So in terms of that, reducing the number of visits to the hospital, I think we've succeeded in cutting them down in that particular subset of patients who used to come many times previously.
Yeah. We have done not so much for the base hospitals. We have had telemedicine almost from 2004 onwards, basically in the vision centers, in the primary care centers. So there we know for sure the technology of telemedicine has very dramatically reduced the travel required by the patients. Like for example, we're able to resolve close to 90% of the patient's problems through teleconsultation. In the sense, the diagnosis and the intervention all happens, medicines or glasses all happens at the vision center itself. So our referral rate is quite low. It's about 10 to 12%, may go up to 15% in some centers. So that has been there. In terms of reducing the visits to the base hospitals, we have been already quite thin on that in terms of the number of visits they make, because we monitor them. Now, like for example, in the optical shop, one of the metrics is what proportion of glasses got delivered on the same day, and then the metrics for the same day delivery used to be 90 minutes. Now it is down to 30 minutes. So we are just doing all that because to the extent that you reduce the effort to the patient, the compliance also goes up. So that's another factor. But in all honesty, within the hospital, we have not had great success in using telemedicine yet. But then graduating from COVID, we are trying to make it into a much more of a mainstream process. But the uptake has not been great on that front.
Right. Before we move on, there are a couple of questions in the chat which I thought we could take right away. So you spoke about the DWAT model that you have for STP. Can you just elaborate a little bit on it, and then whether you help other eye care hospitals with the implementation of this particular system?
Okay, I'm not technically very savvy on that, but at a high level, what I know is it's a totally an organic system. Now, wherein you put you collect the wastewater from toilets and everything into a concrete tank, which is typically we submerge it, because then you can use the real estate for parking or whatever, and then after some time it is pumped up, and then that's the only power that you use. Because filling in the tank is gravity, but then we have to do one pump up for it to then gravity feed through multiple beds. You need it's ideal to have some real estate. It requires some space, but if not, they now have a newer version wherein you don't require. So the final polishing happens in literally below a flower bed, so that whole area also looks very beautiful, where the water comes out. And finally, the water that you get out is odorless and of pretty good quality, but there is some stigma to it, so we reuse it for gardening and for flushing and things like that. This was developed by a German NGO. They're based in Bangalore, so they're very willing to provide all the technical know-how to do this. And I can send offline the links to you or to Raja or to Arnas, who can share with the participants.
Okay. Yeah, thanks. There was one more question related to, whether if you had to choose between having a renewable energy source within your system or a power purchase agreement, what would be better for an eye care system?
You will really
go ahead, sorry.
Yeah, you will have to go for both, because I'm just getting this rule of thumb, having done it in all our hospitals. I think in-house solar, unless you have huge amounts of land where you can put in a solar farm, then you should go ahead and do it, because it pays back in a relatively quick time. But if it is rooftop, it would normally cater to 20% of your power needs, 15 to 20%, depending upon the footprint of the building. So you really, for the rest, you may have to go for some purchasing arrangement. And that's what we have done.
Okay. Right. There's one more question, but I'll leave it to a latter part when we're discussing about the government, because it's actually related to that. I don't think there are more questions on that, but I want to ask you now. So we've been talking about the renewable energy, the building infrastructure, operational efficiency, reducing, patient movement of patients, or reducing the number of trips that they make. Okay, what has been happening in terms of, like the consumables that we purchase? So you realize that when I was looking at data from the NHS, because they've also analyzed how cataract surgery the consumables there contribute to about 50% of the greenhouse gases. And when we're talking about purchases, it's for the audience to understand, it's basically all the material that you procure from the company, right from where it is sourced all the way to you receiving it and using it. That itself generates a huge amount of greenhouse gases. So did you look into this aspect when you were trying to analyze Arvind's carbon footprint for cataract surgery?
Yeah, certainly. Yeah, in Pondicherry, several years back, we launched a program of zero waste, saying that nothing will leave the hospital campus. No, we have not really achieved it, but we are pretty close. So to that, I think one has to do multiple things. One is beyond reducing your consumption, making sure that inventory holding is so efficient that you're not having any dead stock or stocks that you have to throw out and things like that. So our stock holding is on medical consumables is between 4 days to 1 week, something like that, very tight kind of. And we're fortunate to be in a very competitive market. So the response time from the industry is good. And then, so two things contribute to carbon footprint. One is packaging. And this is where some of because we know that you open an IOL box, the IOL is such a tiny thing, you throw out possibly 100 times or more in terms of volume from the packaging and the listing that we give. Nobody even reads that. But then the law requires you got to put in all those inserts and so many copies and all of those things. So there is some work now happening to lobby with the government to see whether we can now get onto QR codes and those kind of things. So in case somebody wants to read, the information is available. It doesn't need to be there in every packet. And some of the inserts, when you open up, are as big as a newspaper. Because they say put in multiple languages and all. It's a bit of a mess, the regulation part. So packaging is a big part of doing it. And the other part is the transportation of your consumables coming into you, and that depends quite a bit on your inventory supply chain efficiency. Now, if you're not well organized and you're making too many emergency purchases, then I think that those trips add up. Either you are running out, sending somebody to get some stuff, or you are so big that your vendor has to immediately rush something to you, which otherwise you would have sent it along with the next consignment. So very good inventory management again can reduce this thing. And today, I think many of these processes are developing. Library stock. Now you engage with the vendor to say that, okay, you give me this stock, and then you replenish it every week, every 10 days, every 2 weeks based on our consumption. Thereby you kind of optimize on the number of transport trips made to bring in your supplies. So I think those kind of approaches is what we have been moving towards.
Yeah, I think that's very important. The fact that Aurolab is located very closely to your main campus, and also you're able to transport material from Aurolab, has that helped in reducing the carbon footprint? Because you're pretty much almost self-sufficient with most of the stuff that you deal with, right?
In a sense, yes. Yeah. So that does have some advantage from this particular lens that you have. So to some extent, it is true. Yeah. Yeah.
So I hope that there'll come a day when we have an IOL coming in a pack that's like a blister pack that we use for contact lenses. That will be really fantastic if we can reduce it to that size compared to the huge boxes we have now.
Yeah, I think we should. Yeah, I think we should. Yeah, I think there is already some movement, lobbying with the drug controller and others to bring this about. But I think if the users as a group lobby for it, I think it'll be much better. No. Yeah.
Okay, so this is one of the questions that I didn't actually preempt you with. But do you think that the companies are doing enough? Because see, when you look at the West, so a single cataract surgery, they use a disposable gown, disposable gloves. Some of them use a disposable mask for every patient. They use a single eye drop bottle for maybe 4 drops of Midriatic per patient. They use a single cassette, a single-use disposable blades. Everything is moving towards a single use. And even now we have preloaded injectors of IOLs, where you have an IOL is preloaded, and the amount of plastic that you generate with that single intraocular lens, all in the name of, yes, we want a sterile item to go inside the eye, minimize the risk of damage to the lens and damage or exposure to contaminants. So do you think that the companies have made any efforts with this ongoing effort of the globally what we're seeing with climate change? Do you think that the eye care companies have actually done anything to change their strategy to a better one?
There's such a huge conflict of interest. So I really don't think they will take the initiative to do this.
Yeah, so that's actually very unfortunate that they don't realize how much they make us do because of that.
Yeah.
So
yeah. In fact, they probably will push for the opposite. They just to like for example, why wouldn't they give an eye drop bottle with a narrower outlet so that smaller drops fall out? No, because I think the amount of drug that goes into eye is a lot more than what is needed for therapeutic reasons. The same bottle with a nano dropper should probably last much longer. No, but that's not in the interest of the manufacturer. No.
Yeah. So agreed. So there's a huge conflict of interest there, and a lot of this is driven by them wanting to increase their profits, and so therefore they come up with all these wonderful gimmicks that they force us to use in the name of sterility and stuff like that.
Yeah.
Okay. So there's a question here related to air conditioning. I'm not sure if we all have the technical expertise, but then Shashank is asking if air conditioning uses a lot of power. Is there some way that we can use water, and what are your thoughts on how to keep an institute cool during summer to avoid excessive air conditioning usage?
I don't know, but I think in air conditioning itself, there are technologies now that are a lot more efficient. I can tell you about one particular instance that agreement that we have got into. In Madurai, we've engaged with a company called as Smart Jewels. The deal that we have with them is they would take over the entire electrical whatever connections related stuff in the Madurai hospital, and they would make all the investments to make it more energy efficient. And the main investment, which probably ran into 1 crore or more, is on the air conditioning chillers, replacing it and reconfiguring it and redesigning it, and all at their cost. So the deal is that they establish the baseline power consumption, and then what they do would reduce the power consumption by us, which means on subsequent months we get a lesser energy bill. No, so we split the savings with them. No, we get 25%, they get 75%. So it's kind of a no-brainer for us. No, we end up gaining some money, and this is for a certain period, beyond which we get 100% of the savings. And then, so they have told in most instances, they're able to have this breakthrough savings in the air conditioning, which kind of, if I flip it around, to me, it seems that most of the people who advise the builders on the design of the air conditioners are probably probably have no knowledge about the energy side of it. They're probably more influenced by the brand or whatever other considerations they may have. No, so an energy audit may be the first thing to be done to figure out how they can reduce their air conditioning bills, and then go for other options. Yeah.
Yeah, agreed. So, so actually, it would be prudent to hire these kind of organizations which actually would analyze your energy efficiency or inefficiency, and then kind of make suggestions. And I think we've had some experience with that in LVP also, where we've kind of used different kinds of methods. Like autocapacitors was one of the things that we looked at to try and help reduce our energy consumption. And every now and then we up our load so that if you'll end up using more, because as you expand, obviously you will end up consuming more electricity. You increase something somewhere, you're going to use more electricity there. So you have to be very mindful of what steps you're taking in order to kind of mitigate that effect. So yeah, so I think that's a very useful point that I think a lot of people would take home with them about getting this audited on a regular basis and see how you can make changes. Yeah. So okay, so I think one thing I'd like to laud Aravind for is the fact that you have accommodation for your staff within the campus, and quite a large percentage of staff do avail of that facility, which means that their carbon footprint from the transport that is avoided is significantly reduced. So I think that's something that we could consider. A lot of people could offer that option to their employees, and that would help. So what are your thoughts on that?
I mean, to us, this whole thing around trying to reduce the staff, of course, when we built the quarters, the top of the mind reason was not carbon footprint, to be honest. It was to have the staff available for the hospital. But then we realized that it completely eliminates that aspect of it. And even when children have to go to school, from inside the campus, we do some carpooling and try to minimize the effort. Even for patients, like we do a large number of eye camps. Each year we see more than 500,000 patients through outreach, and close to 100,000 of them get operated, which means they have to be followed up after 4 or 5 weeks. So in the very early days, we used to ask the patients to come to the hospital. But then later we realized that the patients are not able to come. So for the last almost 3 decades, we would go back to the campsite to examine the patients, which again eliminates each person making a trip. And again, same way when we used to advise patients to come for surgery, in the first 2-3 years, we used to ask them to come on their own. Again, very few were showing up. And there again, busing them all as a group and busing them back. So one thing that as providers we can recognize is that we have the power to consolidate and have scale. Which scale is fundamental for efficiency and to help with that. And when we forego that luxury and tell each patient to fend for themselves, to come and make those trips, we lose that opportunity. So leveraging that again would reduce consumption.
Yeah, that's true. Okay, so let's change gears now since it's already 7:40. Basically, what are the challenges that you faced, in this endeavor?
I mean, in our case, I really don't recall any challenges, because I think if you look at the design of all these processes, they tend to be a win-win. Now, win-win in the sense, it reduces cost to us. So it will be really dumb not to do it. No, why not consume less power? Because if you consume more, you're going to be paying more. And then this process, the way we have designed, also reduces cost and effort to the patient. So the patients are happy that they are not spending more for it. And then this combined outcome of this is reducing carbon footprint. So because we have been sort of engineering this kind of a win-win kind of a situation, the resistance had been quite low. The only time we had challenges was in the very early days, when the investment had to be made upfront. Like the very first time we were exploring DWAT's plant was in Pondicherry. That time it was not very prevalent. And there again, it happened out of necessity. The groundwater level was at 4 or 5 feet. So we couldn't leach the water into the ground, it won't absorb. And there was no common drainage, central drainage was not there. So we really had to come up with some idea, and we didn't want to go the chemical treatment way, for general ecology reasons. So that required a pretty stiff investment. Now we had to invest about 2 to 3 crores. Now, because we had built something to process about 3 lakh liters a day, which was the estimated throughput at full occupancy. So then there was a lot of back and forth, for us to make up our mind, to go that route. But finally we did, and thankful we did that. Because that, I think, spurred that whole movement in the country, because that became the Asia's largest DWAT's plant, and and that itself, I think, reinforced us to do it in every other hospital that we have been building since then.
Yeah. Okay. So I'm going to ask you about the role of the government. So do you think that they're doing enough at this point of time? What do you think that they should be doing differently?
I think the government, they do a fair bit of, they've signed up to this stuff, to reduce carbon footprint, that is for sure. But operationally, it is not really happening yet. And I think there are a lot of stuff that they can do in this. Suppose you take the actual caregiving process. You have a lot of vision centers. We have a lot of vision centers. I'm sure many of the people in this webinar also have vision centers. Now you know that it's not easy for you to close the loop at vision centers, because the law is either against or gray, in the sense you can't sell medicines in vision centers, right? So if you can't sell medicine in vision centers, 2 things happen. One, you're not sure the patient is going to get the care they need, because then you're completely you don't know they buy the medicine and use it or not. Once they leave the vision center. Second is, if some patient really wants to buy the medicine, they really will have to travel quite a bit, because most of the vision centers are in remote areas. And even if there was a pharmacy, very unlikely they'll carry ophthalmic drugs, which is sort of a specialty. So that's the one simple thing. If only they would allow us to sell medicines in vision centers. So today, I think collectively we must be handling probably a couple of million patients through vision centers. I'm talking about all vision centers put together. You can imagine the effort that would go there. That is one example at that end. Second, like I said, they can bring in some laws about packaging, because technology is there today, QR codes, internet, everybody has access to it. They can question why we need to put so much paper into it. They can bring in certain laws to, which again will be a win-win, because the pharma industry, which does all the supplies, will be very happy to reduce the packaging cost. They won't pass it on to us, so it will go into their bottom line, but at least the carbon footprint goes down, both on transportation and on consumption of materials. The other area is all around energy. I think they have to do a lot more there with better coordination between the center and the state governments, so that they really enable at all levels of power uses. I mean, today in Tamil Nadu, it is very strange. Like at my house, I'm net zero in terms of I don't use any grid power. In my large hospitals, I'm able to become net zero. But then the secondary hospitals, which are smaller, they're on to low tension power. The rule prohibits us from purchasing solar power and using it. No rationale at all. Zero rationale. So I think these kind of changes have to come about.
Yeah, I agree with that. I think even the taxes that they levy on, the say solar panels, for instance, like that has just gone up phenomenally in this financial year. They've stopped the imports from China, so it's making things a lot more difficult for those who wish to have solar energy, the setups in their hospitals. So it becomes more challenging. Becomes more investment is greater. Though okay, the long term it does pay off, but then it becomes a little cost prohibitive for certain organizations to manage. Okay, so the other thing that I would like to ask you now, and this will be the last question because we are kind of closing in on 8 o'clock, is what would you suggest to individual practitioners, small and large hospitals, if they want to start? How should they go about it?
So to me, I think 2 or 3 areas they can work in. I think one area is just to look at consumption. How much are they using on the energy front and so on? And like you already mentioned, getting someone to do an energy audit, to say the areas where they can consume. And then we have done the math, like changing bulbs into LEDs or fans into smart fans, literally pays back within a couple of years in terms of energy savings. So that is one easy area to start. The second area to work in is to look at their own service delivery design. Are they completing your patient's problem with minimal visits? Because sometimes there may be a feeling that if I make the patient come many times to the hospital, I'll earn more, through consulting fees or something like that. But that I think is really not the case. Because every time a patient comes to you for, I'm calling it an unnecessary visit, or a visit that could have been avoided, they're taking up your capacity of your patient with a genuine problem coming in. So your revenues also come when you have patients with problems coming in, either new patients or review patients. So eliminating unnecessary visits is again a thing which I think the patients also will appreciate in the long run, and your practice also will definitely grow, and then focus a lot on productivity and efficiency. So all that I'm saying is that actually it's a win-win. All of this we should do in any case to have a successful practice, but all of this have a very direct bearing on reducing the carbon footprint as well.
Yeah. So I think just 2 things that we didn't actually touch upon. One was the importance of electronic medical records. And I think that has helped us in reducing paper in a big, big way. There are certain things that are inevitable, but I think with the introduction of electronic medical records, I think that's one aspect that we have actually succeeded in reducing the utilization of paper, folders, etc., etc. Printing of receipts, printing of medical reports, all that has come down significantly. And I think the other thing that I wanted to discuss was pertaining to recycling. So I think that was one area which the government is not doing much. There's not enough happening where you can actually segregate items at source, get them recycled. So you know that, okay, this cardboard or this piece of plastic is going to go to this vendor and it's going to get recycled. So I've done my bit in terms of ensuring that it gets reused somewhere. You know, it lands up going into landfill, which doesn't serve the purpose. Incineration of biomedical waste, whatever goes into our yellow bins and red bins and stuff like that, that part of it we cannot avoid being healthcare organizations, but there's a lot of other waste that we generate which we don't actually take care of by recycling. And I think that's something that the government can help with.
Yeah,
okay,
absolutely.
so yeah. So I think we've reached the end of our of the discussion that we wanted to have with you. Thank you so much. The answers have been very, very insightful. I'm thinking that there should be a lot of people going back from here with ideas on what they want to do next and how they want to do it. But if there are any questions that the audience would like to ask, they can just unmute and go ahead and fire away.
Yeah, Merle, can I ask one question? I have one. It's a kind of a comment. And also a question in that, first of all, again, a wonderful discussion, and thanks for enlightening us. What I gathered is, a lot of system-based changes. People in the senior level management have to design and devise, but it's not easy to understand for an individual level person or a layman as to how they are contributing to this movement to a sustainable planet. Apart from the cost saving, let us say, maybe that is something which may be tangible for them a little bit, but there is a bigger picture that we are looking at when we say, reducing carbon footprint, green planet, sustainable planet. And in that context, I just wanted to know how, at an individual level, we can create a mass movement. It may be linked to some incentive. There are multiple aspects to it, recognitions. But at some point, I feel that a mass movement is required. And the point of the government also, what they are doing, they're signed up to it. Signing up is one thing, but I was telling in my introduction, has it become their DNA? I'm not sure about that. I'm not saying the government is all of us. I'm not sure if it has become the DNA of all of us. The government is not something different from us. But the point is, when we say that, we are as a government, they remove trees, cut trees for whatever other infrastructure development, so-called. And there is hardly any word on replenishing that, deforestation or the number of trees that they have cut. Is someone monitoring them? Recently, I heard that Europe is trying to ban short-haul flights, whereas we are trying to increase connectivity with short-haul flights. So somewhere there is some correction required as a mass movement, which has to come from the individuals. The people have to, make it visible that the government also is looking up to the people are, following these. So any suggestions on how we can make it as a mass movement where the individual person can also play a role?
Raja, I think you're raising a very challenging question. I don't think I have a ready answer, but something which might is that if we can come up with a easily understandable measurement. I think this whole notion of air pollution was talked for a long time, but I think the awareness amongst a common man has increased quite a lot. Now, once they started actually having a way of showing people how clean or bad the air is. Now, almost every public place you go, it says what is the level of whatever carbon, sulfur, and different pollutants, which creates some level of awareness amongst the people. I think we are quite far away from that when it comes to carbon footprint. But then if collectively, whoever have the brilliance to do that can come up with something, that may be a starting point. Usually holding a mirror and benchmarking are the two things which promotes or triggers change.
Yeah, thanks, Mr. Tulsi. I think just as an example, in healthcare, at least excess calories, overeating, we have somehow been able to bring it down to an individual level, that person will also have some side effects of obesity, diabetes, hypertension, and everyone probably wants to cut down on calories. Similarly, if there is a way to show, what you did today, this was the carbon emission, net carbon emission from your activities, or it could be, uh, how we project it to an individual level. And from there, people can start seeing and calculating, now I have to reduce further, like counting your daily steps, footsteps, kind of. So if that can be done, and, people can start participating and tracking, I think that would also help a long way in a sustainable planet.
Yeah.
Thank you so much. Thank you so much, Mr. Tulsi and Merle.
Thank you for this opportunity.
And for the participants for asking the question. Wish you all a good evening. Thank you.
Thank you. Thank you.
I'm not sure if there are any questions in the chat, or if anybody has any that they want to ask.
I don't see any at this time.
Yeah.
Yeah, Manoj had put something about other water harvesting options other than STP, if you were aware of any.
What's the question? Other than STP, what harvesting?
Any other water harvesting options?
I'm also not aware of, because rainwater harvesting one can do, but for institution level, it gets to be a challenge. Because it gets it's difficult to kind of control its use. Like for like in our house, for the last 25, 30 years, our drinking water is all rainwater. We can do it in our house, but not sure how one can do it in an institution. Yeah, I agree. It's a little challenging, but then there are companies actually that are promoting these kind of projects where you feed directly into the water table aquifer. So you can actually harvest the rainwater and then feed it into the aquifer, which then benefits you in the long run, and community at large. Yeah, that can be done. Yeah.
So I don't think there are any more questions. Thank you, Mr. Thulsiraj. It's been really informative. Yeah.
Thank you for the questions.
Thank you so much. This has been a great learning session today for all of us. And on behalf of Team IHOPE, I would like to thank Tulsi sir and Dr. Merle for giving, this very enriching, educative session. There is, of course, a long way to go, but every drop makes an ocean, and we shall all strive towards making our bit of difference to the planet. Thank you so much.
Thank you, Arnas. Yeah.
Thank you so much.
Bye-bye.
Bye.